Good morning, everyone. We are here today for our USF Health International Global Health Conversational Series. I am Dr. Perez Colon. I am an assistant professor for the Department of Medicine in the Morsani College of Medicine. And I am here today to introduce your speaker, who's going to be talking about COVID-19 management as an outpatient. Just as a little bit of a housekeeping, first of all, the meeting is going to be recorded. We are going to share the link at the end of the conversation, at the end of the meeting, for all of you to enjoy and share. Please mute your microphones if you are not speaking. You can also ask questions to the speaker, which we're going to be answering at the end of the conversation through the chat. So if you have any questions, you can input it there. Thank you again for joining us. And it is my pleasure to introduce today's speaker, who is my colleague and good friend, Dr. Asa Oxner. Dr. Oxner is an associate professor at the University of South Florida, Morsani College of Medicine. She is also the associate program director for our internal medicine residency. She is also the vice chair of clinical operations for the Department of Internal Medicine at our institution. She is also the medical director for the outpatient services for USF. She's the COCO clinic or COVID-19 confirmed clinic for USF. She's the clinical operations director as well. And she's going to be discussing with us all of the outpatient management for COVID-19 today. Dr. Oxner has extensive experience in global health as well as disaster relief. She spent 14 months in Sierra Leone managing the Ebola crisis. She also has been a part of multiple other quality improvement projects abroad in Africa as well as Latin America. She has been coordinating and leading efforts to assist after hurricane relief in both Puerto Rico, Bahamas, and other areas of the Caribbean. It is a treat and a pleasure to have Dr. Oxner today speaking to us about how we have been managing the COVID-19 pandemic in our institution.
Thank you very much, Dr. Perez Colon. So Dr. Perez Colon, as she said, her and I have done a bunch of mission trips together before in Latin America and in the Caribbean, and then we were partners in crime in this COCO clinic because she is the medical director and I was the operations director. But then since I'm more outpatient and she's more of a hospitalist in our other job, I'll do most of the talking, but I'll call her in for certain slides as we go through this. So I think I'm sharing my PowerPoint now. Is it working? Okay, excellent. So yes, we're going to talk about this clinic that we call the COCO Clinic, which stands for COVID Confirmed. And we really wanted to share it with everybody as a potential innovation that we think is pretty scalable and translatable to all settings that you might be working in, whether more rural, more urban, whether underserved or well-resourced. It's something that we think could be pretty scalable to that. So we wanted to spend the majority of the time really literally just get to the meat of stuff. I think that most of the people who are going to be interested in this talk already knew the background of COVID and the pathophysiology and those things, although we may touch on a few when we talk about our treatment protocols. But I wanted to spend more time on the actual implementation model. And then sometime at the end, also looking at how this was able to be leveraged as a pipeline for research at our institution, because that's also something quite scalable. So in detail, this will be the agenda. The clinic literally is an entirely virtual ward or clinic, depending on whether the patients are on continuous monitoring, then those are more similar to a virtual ward. If they're not on continuous monitoring, then it's more similar to a virtual clinic, but it's all virtual. So we'll go through the workflow that we set up, the staffing model, our triaging system, and some of our assessments and documentation. We'll show you an example of that. We have our treatment protocol that we'll go through. Some of the, an example of the 24/7 vitals monitoring that we do. We'll show you an example of that, and an example of some of the things that we say to patients and families, at least the stuff that comes up the most commonly that we go through with them. And then we'll talk about research at the end. So here's our flow chart of the workflow of a patient. So a positive test gets reported, and then that we get that list once a day uploaded to us. We have a box folder, which is a HIPAA secured cloud-based storage. So that's where we get the list uploaded to us so that it's secure. Then we have our team of students who call the patients. And they make a few decision points, like if it's a transplant patient, then we have a specific transplant infectious disease team who follows those patients, but that's, I would say, less than 5%. So I think like 95% of these people come into this box here, where the medical student conducts their full risk assessment using a score that I'll show you in a coming slide. And then they use that as the same that they would do if they were doing an H&P on the ward, where they decide, this is an emergency, I need to escalate it to my senior right away, or this is not an emergency, I can give them advice and they can manage it, or this is something that we're going to talk about and we'll do a close follow-up with the patient. So they make that assessment and plan just like they do as senior students on wards or in clinic or anything else. And this is our staffing model. So basically we could handle up to 300 patients a day. And we did do that a couple of days in July, although, most of the time it's maybe closer to 100 patients, luckily. So we have one attending. It is 90% of the time it's either Dr. Perez Colon or myself doing the attending stuff. And then we have a few residents. We try to have 3 residents or an APP. So normally we have usually 2 residents and 1 APP, which APP for us means advanced practice practitioner. So these are more senior nurses or physician's assistants. That's what that means for us. And they each supervise about 4 students who have 25 patients each. So they each are supervising up to 100 patients. Along the bottom is a couple of our statistics. So our no-show rate, which means like no answer rate because it's actually all virtual, but the rate of people who just don't answer the phone at all is about 30% every day. Even if we've already talked to them before, they still have a high chance of not answering the phone on repeat calls. The frequency that we call patients back is every 2 to 3 days, unless they're the highest risk patients, then we would call them every single day. The average length of stay that patients remain in our clinic is 10 to 14 days, but we do have some that re-refer to us like 90 days later, that they're still having ongoing symptoms that they never had before they had COVID. So we have some longer, but the average is 10 to 14 days. And overall, since March 30th, when we started the clinic, we've taken care of more than 4,700 patients. This is old statistic because I can't update it every day, but this was updated about at the end of last week, so it's even higher than that at this point. So it's quite scalable to large scale. for sure. So this is the triage system that the students use when they're talking to the patient. This is adapted from Massachusetts General Hospital guidelines. They have their website that you can look at, and they update it periodically. At Massachusetts General, they do have another column for laboratory results because they have inpatients primarily, but we often don't have any laboratory results on our patients like a D-dimer or a troponin. So we have basically removed that section, but taken the rest of what they have. And I think that this version that we're using is working really well to help us stratify the likelihood that a patient with COVID is going to decompensate so that we can follow them up more closely if they have more of these risk factors, or we can follow them less closely to open up capacity for ourselves if they don't really have any of these risk factors. And so most of these you can see are things that you would get from history, from talking to the patient. Certainly you would get their age and then their comorbidities like their diabetes, cardiovascular disease, chronic kidney disease. You would get those. Some things may come from their medication list. Biologics for us are used a lot in patients who have autoimmune diseases. And so you would get that from a combination of their medication list together with their past medical history. And then transplant or immunosuppression, again, we ask a lot of the patients, but then immunosuppression, we do ask them specifically about their medicines, including steroids or other immunosuppressants like methotrexate that would put them in this category. And then their vitals. The students ask the patients their vitals when they're to check them and renew their vitals when they're on the phone with them. We give most of our patients a fingertip pulse ox that they can monitor themselves, and which will include their heart rate and their SpO2. So most of them do have access to that unless it runs out of batteries or some reason like that, but it's usually available. So this is what we use for our triage system. Our cutoff is about a score of 2. So if you score 2 or more, then we categorize you as, at least moderate risk. If you're more than 7, then you're high risk. So those people that are 7 or more, we follow them every day, and they would be the ones to qualify for the 24/7 vital sign monitor that we're going to talk about. The ones that are between 2 and 7, those are really the ones that we would follow every other day and keep a close eye on them as they're going through their illness. The ones that are scored less than 2, we often will say, we'll call you one more time, at the 7-8 day mark, just make sure you're doing fine, but we don't expect you to have complications from your COVID. So the next thing I was going to talk about is our documentation. This is the whole note. I had to put it in 2 pieces, but it's literally a screenshot of the actual note that the students complete. So the reason that I included it for you guys is that I wanted to talk a little bit about how important it has been for us to really do a whole person assessment. And you'll see this second paragraph here that we have the students ask the patients literally what are their own goals, what are their barriers to those goals, because we found that COVID is so entwined with social determinants of health and access to healthcare or access to medications or food or masks, that we find that these questions really help open up a lot of things that we need to do to be able to help patients or families. We need to connect them to resources in the community. And so if we didn't ask that, then we wouldn't be able to we wouldn't ever know, literally. And then over on the second screenshot, the second page, so to speak, We actually have a PHQ-9 and a GAD-2, which the PHQ-9 measures screening for depression, and GAD-2 screens for anxiety. And then we added a fifth question about alcohol and recreational drugs, because at least in the US, many people are coping with COVID and isolation by using alcohol and recreational drugs. And we have specifically resources for them, some that are internal with our own USF faculty, but others through a network that was put together in our state in order to help people if they actually are experiencing mental health or addiction as part of their response to their COVID infection, or just to being quarantined and isolated. So that's why I included the literal note that they do. This is the template, and they have to answer each question and click the little boxes. So this is literally what they go through on here. And then we have the plan, which I'm going to go over in a little bit more detail in a few slides coming up now. So our treatment protocol, this is the simple version. The next slide has a detailed version of it for you guys. But in summary, our treatment protocol is we recommend vitamin D for everybody, even if they're very low risk, even if their risk score is 0 on that calculator. We still recommend vitamin D because we really don't see how it has any harm, and it can potentially be helpful in some of the studies. There was a recent study about zinc being helpful, and so Dr. Perez-Colon and I have to get together and decide if we'll add that to the vitamin D part. But for now, it's vitamin D, and this has been going on for months. The next one that we recommend is we actually explain to patients how to do prone positioning at home. So the students, physically tell them to lay on their bellies. We ask them if they can do it as many hours as they can per day, but we give them a goal of 1 hour every 4 hours. So almost Q4 hours to do prone positioning at home. Again, unless they have some kind of physical disability, the harm in that is 0, and the benefit could be very high. So that's why we recommend that for everybody. We also talk about atorvastatin 40 milligrams daily with every patient. There is a very strong study that showed that that was helpful, which I put in the references section for you guys. So only if patients have contraindications like previous allergies or reactions to statins, then we would say that they don't need this. But otherwise, we do ask them to take a statin. Then we have two things that we recommend, but not to every patient, to some patients. So if their SpO2 drops below 93%, then we recommend prednisone 40 milligrams daily for 10 days. That is based off of the original study of the recovery trial, where they used dexamethasone 6 milligrams daily for 10 days. So not all of our community pharmacies have dexamethasone. Our hospital pharmacy does, and if they're on dexamethasone, we leave that, very happy with it. But some of the community pharmacies don't have that one, so we made the equivalent dose in prednisone. Since the recovery trial, there have been additional studies that have come out on steroids that also show a benefit. So I put a bunch of stuff in the references section for all this stuff for you guys, but there's now multiple well-designed trials that show a benefit to steroids. So we do give that for patients who become hypoxic, which we define as less than 93%. The studies do have different levels of hypoxia in each of them, so we just had to pick our own kind of cutoff that works well for our patient population. And then the other thing that we recommend for some patients is if they were hospitalized, then we ask them to take apixaban 5 milligrams twice a day for 2 weeks after their discharge. this one, the other people that would potentially get that would be people who are have a history of DVT or pulmonary emboli, or who have other risk factors that are going to make them very high risk for that, like if they are pregnant, if they have a history of multiple miscarriages, if they have cancer, or if they're morbidly obese. Then we would, all of those people would fall into this category that we would actually want to anticoagulate them. The data for this, I also put in the references section for you guys. The data is at this point not strong for this recommendation, but the data is strong for inpatient prophylaxis of COVID patients against DVT. And so that's why we selected only the highest risk group to continue any sort of anticoagulation for. And when I talk about the pipeline for studies, I will talk about one of our studies where we are actually randomizing people in the outpatient setting with COVID to placebo versus anticoagulation to look to see if this is something that is very helpful for them. So here's our detailed treatment protocol, and it includes in here the references which are numbered on the last slide, so you guys can look back and see, you know, where the heck does this proning idea come from? What is up with the vitamin D? So those are referenced in this section. The other one thing from this page that I didn't talk about already is apixaban is quite expensive, and so we do have a lot of patients who cannot afford apixaban as their anticoagulation prophylaxis. And so, although it's completely not studied, we offer aspirin 325 milligrams daily as a recommendation for those patients who are, again, very high risk, like prior clot history, they were hospitalized, or they have a high propensity for clotting, but they can't afford apixaban. Then we discuss aspirin 325 with them instead as an alternative. And so then the last part of our treatment protocol, which I referenced when I showed you the documentation about how we really focus on whole person care, is a referral to mental health, or at least an offer of a referral to mental health. And our mental health team, they actually prefer to be called our wellness team because they help people be well. They are set up in a similar staffing model as the little grid that I showed you guys. So they also have teams of students who are Masters of Social Work students, or students getting their license in mental health counseling, their LMCH. So those students, they have to do clinical hours just like medical students or nursing students. And so they do their clinical hours virtually. They call the patients who agree to a consultation with them, and then they staff with their own faculty from the College of Behavioral Sciences or the College of Social Work at USF. So far, they have been incredibly helpful. They have, for example, caught and diverted one patient who was suicidal, who was like very actively suicidal, actually, was making her final plans for her whole life and her family. And so they diverted that and helped her. And the last that I heard, she was doing well. I don't know, Dr. Perez-Colon, if you heard anything more recent than that.
Yeah, she's definitely improving and getting the help that she needed.
That's great to hear. And they've got a bunch of patients who they're counseling on substance abuse, because, like I mentioned, it's a common coping strategy that we're using in America. So that's very common. And they've been very helpful to link our patients to longer term resources, whether that is a long-term psychiatry, or if it's some of the smartphone apps for meditation or for cognitive behavioral therapy. But they're really a link to the whole network of mental health, wellness, meditation that's available in our area. So they've been very, very helpful for our patients. And then they also teach us every Monday. This team joins Dr. Perez-Colón, myself, and all of our medical and nursing students. They join us and they teach us some provider wellness so that we can avoid burnout by taking care of the same population as well. So then switching gears off treatment protocol onto another section, which is really our 24/7 vital sign monitoring and assessment. So this looks like this picture up here, where you get this little pulse ox sticker that goes on one of your fingers, and it goes with a wristwatch slightly bigger than an iPhone watch. The batteries in here last about 4 to 5 days. We give people at least 2 batteries so that they should be able to be monitored for 8 to 10 days. If they need monitoring longer, then we arrange a shipment for them to be able to get an additional battery on this. And the things that it monitors is your oxygen saturation, your heart rate, and then your respiratory rate. And this is a dashboard of an actual patient who was on the monitor yesterday afternoon when I took this. He's still on there today. And what it does is it's continually monitoring, and it sends us a page to the team that's responsible for, who's on call for this. It sends that team a page if the patient goes outside of the parameters that we set. So we set an SpO2 of 90%. And so if it drops below 90% for more than 5 continuous minutes, then we get a page. And for heart rate, we set a heart rate of 110. So if the heart rate goes above 110 for more than 10 minutes continuous, then we get a page. And we have our nurses that are, they are licensed practicing RNs. Almost all of the ones that volunteer for monitoring this team, they actually are also inpatient RNs in the COVID ICU at Tampa General Hospital, our main partner hospital. So they work in the ICU at the days, and then they volunteer to take care of the patients on the monitors on their days off. But they get clinical hours from us for them to count towards them being able to become a higher level RN or a physician's assistant. So they're getting some educational hours from doing this with us. So that's the incentive that we set up for them. But we have 2 that do it on day shift, 2 that do it on night shift. And they could each monitor 5 patients. So we could have 10 total. If we needed more than 10, we would solicit more volunteers for doing this. And they can escalate if there's a lot of pages that are coming into them and they can't get the patients to stabilize by talking to the patients on the phone and saying, you know, drink some water or sit down and take deep breaths. If they can't stabilize the patient, then they escalate it to the attendings, Dr. Perez-Colón or myself, for us to help them out, or maybe call in a prescription or refer the patient back to the hospital. So that is this system here is used for our highest risk patients, the people who score 7 or more. And it's from patients who were in the hospital who are discharged. The most common patient that actually ends up on here is a patient who was in the hospital, is discharged to home, but has new oxygen that they never needed before. And, you know, so our nurses are calling them and weaning down their oxygen over the next several days as they continue to get better. So it's really like a continuation of the hospital in that sense. And then the last thing in terms of details of how the clinic works before we talk about research, I was just going to give 2 examples of things that we end up having to talk to patients or families about a lot. A lot of our total time that we spend with each patient is spent on giving them advice. And so this is a screenshot of the advice that we give to some patients. We have this translated in a bunch of languages, and we send it to them. We give them a physical handout if they come to our clinic in person. They can get it as an email through a secure portal. The students talk about it every day when they call them. And so this is, some of the examples. They always want to know, when can I discontinue my home isolation? If I'm not sick enough to need prescription medicines, what's the best thing to take over the counter? What do I do about my family? Could they all get tested? Do they already have it? Those kinds of questions are the things that they worry about a lot. And so our students get very good at counseling on those things. And the other thing that they worry about a lot is, what's going to happen to me? What is my chance of getting really sick, needing to go to the hospital, or of passing away? And so our students do counsel a lot on this. We show our students this slide so that they can have an idea of how likely it is that somebody is going to get hospitalized, that they're going to need the ICU, and that they would pass away, and that the major risk factor for that is actually age. So we counsel the students, we teach the students, and then the students use this information to counsel the patients and families. So then the last thing I was going to talk about is how we have been able to leverage our COCO clinic as a pipeline to do COVID research. And probably the single most important thing that we did is, from day 1, we asked every patient at the end of our clinical management call. We say, okay, you need steroids. We're going to call that into your pharmacy. It'll be there in 30 minutes. And we finish our plan to take care of the patient. And the very last question that we ask all of them is, would you be willing to be contacted by somebody else from the research team if you qualify for any of our research trials? 2/3 of our patients have said yes. That's what our statistic is. 2/3 have said yes. It includes all demographics, ages, race, ethnicity. 2/3 have said yes to that question, which opens it up for us to be able to have the research coordinators screen them and offer them different trials that we have available. Because otherwise they would just be cold calling, and they wouldn't have a very high rate of acceptance. But the other thing that we really had to do is we have a team of clinical researchers at baseline, but they had to ramp up so quickly for all the studies that I'm going to show you guys coming up, that we actually also had to use some of our medical students that are doing the phone calls, or our nurses that are doing the phone calls, and we had to ask them if they would train on the research protocols and transition to actually being research coordinators and research nurses in the short term. So we've got medical students who are research coordinators right now, and nurses who are research nurses instead of clinical nurses, because that was the need that we had to fill quickly in order to ramp up. So some examples of the actual studies we have. I have them broken up into their category. So in the category of testing and diagnosis, we have started a biobank for specimens. We have a comparison trial comparing nasopharyngeal, nasal, and saliva for the sensitivity and specificity of those different collection specimens. We also have a trial comparing our standard of care tests, which are antigen and PCR, compared to a novel machine that's totally new, that's a spectroscopic machine, to see if that is as good as the PCR and antigen. The reason is because that machine is cheaper, so it would be nice. And then we have a wearable device that people wear to help us develop a physiologic signature of COVID decompensation so that we could maybe predict who is going to do poorly 12 hours earlier and get them intervene and get them fixed before they get really, really sick. And I put on there the actual funding. So this is literally the funding that we have already secured from these studies so far as of the beginning of this month. So they're very successful. In the realm of treatment and management of patients who have COVID, we have a monoclonal anti-spike antibody that is from Regeneron, which is also the company that President Trump got this same drug, but he got it IV. So we're giving it subcutaneous for post-exposure prophylaxis of patients. And then we have a study that is comparing the apixaban versus placebo in outpatients with mild to moderate COVID to see if that changes their outcomes. We have a microbiome study in patients who are diabetics and or obese versus placebo to try to decrease their inflammatory complications. And we are setting up a long-term COVID sequelae study for people who continue to have cough or dyspnea or chest pains. And so all of these, well, the top one we're already enrolling and making money on. The other ones we have not started enrolling yet, but we've negotiated these budgets with the sponsors. So again, very successful in finding some options on treatment. And then finally, in the category of prevention, our institution has 2 vaccine trials approved. One is the Novavax vaccine, and that's just anybody over age 18. And then the other is the Janssen vaccine, which is people who are over 18 who also have immunosuppression. And so both of those are approved, and they're going to be, we're already enrolling patients, but we haven't given any drug yet. But we're consenting people and setting them up for their appointments to come in to get this. These are placebo controlled as well, so some will get placebo, some will get the vaccine, but nonetheless, that is also in progress. So actually, it's been a very successful way to take care of patients, but also to link patients to research. And so finally, we wanted to do some acknowledgements, especially of Christine Jennings and Rochelle Idziak, we call Shelly Idziak, who have been the 2 people that actually make the clinic run every day. They spend, I think, 8 hours a day doing it. Dr. Perez-Colon and I spend like 1 or 2 just answering the medical questions and supervising, but they run it every day, day in, day out, including weekends, nights, everything. So they've been fantastic. And then the rest of the USF clinical operations team, that's like the people who do scheduling, the people who run the lab for patients to come in and get tested, all of that, the door screeners so that they keep us safe. All of that team has been, they've all stepped up and helped run this clinic. And then the quality and patient safety department has been super helpful in letting us basically steal their staff and their resources in their budget for this year so that we could transition to do this clinic instead of doing what we normally would be doing. So they have also been incredibly helpful as well. And then I think the last slide is the references for you guys, and I'm sure that we will share this PowerPoint so that you can look through everything. But that is the end, and then we can do questions. I'm going to unshare my screen. Is that what you want me to do, Jesse?
Perfect, thank you.
Yep.
Well, thank you so much, Dr. Oxner, for this wonderful presentation about the clinic. We do have some questions ready, so I will go over them. I guess the first question will be, How did the clinic help unloading the hospital system? The hospital system was not overwhelmed, which is a fact. And how did the clinic help doing that?
Well, that's a great question. I think you could answer that probably best because you're a hospitalist and in all of those meetings in the hospital more than me.
Yeah, well, absolutely. I'll be happy to. So, yes, one of the things that we learned pretty quickly from other people' experiences in other countries, as well as even within the US, is that the hospital system can get overwhelmed pretty easily with the amount of patients that we were seeing being hospitalized and requiring very close monitoring with COVID-19. So one of the goals of the clinic was to, number one, try to keep these patients at home as much as we can. So by monitoring them on daily basis, if they were in the high risk category, we could identify if there is any risk for decompensation. As a matter of fact, through the clinic, we send a lot of patients to the hospital, and some of which were requiring mechanical ventilation or other respiratory support pretty quickly after getting into the hospital. So this close monitoring system that we created through the algorithms allow us to identify patients that were not doing so well, that were having hypoxia at home, that were having increased shortness of breath at home, etc., and sending these patients to the hospital in an appropriate manner so more people were not exposed on the way to get them to the hospital. The other part of things that the clinic was really helpful is that we had really good communication with our inpatient colleagues, me being one of the inpatient colleagues. We communicated with them multiple times a day. We had multidisciplinary rounds every day that we spoke to them about any patients that they thought that could go home. And we were able to send patients home earlier than what we would otherwise. Because we had the 24-hour monitoring system, as well as intermittent monitoring system, we were able to send patients home that require oxygen or require a little bit more intensive care through home health. And we were able to move these patients out of the hospital, freeing up beds a lot faster than what we would otherwise. And I think that was the key to us being successful in having enough beds to manage all of the patients, particularly through our surge in July, August. All right, so the other question is, how quickly did you set up the clinic?
Well, we started the clinic on March 30th, and I think that Tampa had its first case maybe 3 weeks before that, at the beginning of March. That's kind of what I remember. So it was very quick, and it has evolved. It wasn't like this is the current clinic that we described to you guys, but you know, it was a little bit different at first, and it has evolved into this.
Yeah, I think we have our first meeting about 20 days before March 30th. So it took us about that, a little bit over 2 weeks to set up the initial clinic, but it definitely looked very different. So we had to really adjust as we were taking care of patients since the very beginning. Other question is, what happens to no-show patients?
Yeah, so no-show patients, we give them 3 days in a row, where we call them. And if they don't answer for 3 days in a row, then we put them on a different list that we call the chase list. And on days when we're more slow or we have extra volunteers we didn't anticipate, we sometimes go back to the chase list and we try to sort them by their age or anything we might know about them, and try to call some of the high risk patients on that list.
Yeah, absolutely. The other thing is that we always try to get back to the referral, whether it's USF, Tampa General Hospital, or the Department of Health, and try to get a different contact information too for these patients. The next question is, what has been the student satisfaction to this type of clinical work?
So they've been really happy with it. for several months, this was actually their only clinical option because there was no visitors allowed and students were not allowed to be in the hospital because we did not have enough PPE for students to be able to be safe in the hospital. And so they had a complete halt on surgical rotations, medical rotations, OB-GYN, anything, even clinics, outpatient, they were halted from doing that. And this was the only thing that they could do. And so during that time, they were loving it, that they were still able to get credits and that they were able to help out. Even now, it's embedded within one of their mandatory rotations for medical students, pharmacy students, and nurse practitioner students. So they're still getting credit for it, which makes them very happy. And then some people volunteer above that credit amount because they really feel that this is a way for them to give back to the community. And they have either been impacted by COVID or their family has or something like that.
Yeah, absolutely. I just wanted to add really quickly that some of the feedback that we have gotten from them is that we do educational sessions every day, about 15 minutes or so. As Dr. Oxner mentioned, on Mondays is about wellness. And then every day we have a different topic. And one of the things that they have said is that they have learned a lot about the disease itself, which helped them educating patients in other settings as well, post-COVID. The other thing is that they feel that they are giving back to the community, which is one of our pillars of our values at University of South Florida, is giving back to our community. So I think that those two things are what resonate with me from the feedback that we have received from students. The next question is interesting. I think you're gonna find this one very interesting. Did patients have any issues or complaints about telehealth visits? I imagine most patients are older, and you imagine correctly. So talk about those telehealth visits and what we've done.
Yes, it definitely is one of the challenges. So sometimes, we can only connect with them just on listening. We can't see them. And that usually works better because most people are familiar at least with talking on the phone about things. So that's kind of our fallback that we go to. And then I would say, elderly patients, if you finally do get them on the phone, they really enjoy talking to you. They'll talk for a while because they've got a lot to tell you. What I think has maybe been more challenging is non-English speaking patients, because then you have to call the translator line and then connect the patient in a three-way call. And that is a lot more challenging than just, an elderly patient in a one-way phone call. So we do have a translator line that we have it available for all of the students. They know how to use it, all of that stuff. But that is more challenging for sure, especially some of those 24/7 monitoring patients who they can get sick at any period of time. And we had a couple, a husband, wife, who were Haitian Creole speaking, and that was quite challenging. So I think we had to engage their daughter and some other people to help us to monitor them to do that.
Yes, and that the daughters end up having COVID themselves. So we had to do a lot of education with that family, and it's a lot harder when we are doing it through a translation service. And for perspective, I know that there's people around the world here. Tampa is a very diverse city, so we have people that a significant amount of people that speak Spanish. About 20 or so % of our population is Hispanic, and a big percentage of them, that is a little bit easier because we have a lot of staff that speak Spanish, but Haitian Creole, we had Arabic, we had a lot of different languages that certainly pose a limitation in our communication.
We have a Swahili refugee community that has about 200 individuals, and they did have some COVID in there. So like that sheet that I showed you for advice and stuff, we had one of their community members translate that into their dialect of Swahili. That was a whole interesting experience. And we did a Zoom call with many of them. Anybody who was willing, we did a Zoom call and let them all kind of have their voice and ask their questions. And their community leader was on there that took the lead on answering the questions with us as backup. So we've done all kinds of things to try to get the message out.
Yes, absolutely. The next question is how do you determine or categorize which patients are going to receive the vaccine?
So what we have done is, of course, the sponsor, like the pharmaceutical company, they have their inclusion and exclusion criteria. But what we have done is we set up a website that basically, and then we're going to do radio and TV ads about it. And so we're going to say, you know, anybody, if you're interested in maybe getting a vaccine, go to this website and answer the questions. And it will then, if they qualify based on the inclusion criteria of the study, then it will say, you may qualify for the vaccine. We're going to call you within 48 hours to talk to you more about it and to do consent. So we offer it to anybody who agrees, if they meet those criteria. The criteria, you know, they include a lot of things, mostly for safety right now, because this is a brand new vaccine. So, for example, they don't let anybody who's pregnant or breastfeeding or may become pregnant. So you have to agree to take contraceptions or to remain abstinent during the trial period. They're excluding children because they don't know what's going to happen with kids. They're excluding patients who have cancer in the past 5 years. They have a lot of specific criteria because this is, although they've done the safety trials, this is still going to be the first 30,000 real patients, real live people that they give it to. And so they're trying to make it as safe as possible at the beginning.
Yes, absolutely. All right, the next question is about some of the consequences after COVID. What are you telling the patients that is the prognosis in general?
So that is something that we're still working out. We have a working group with pulmonary, cardiology, neurology, hematology, and mental health experts, and with us. And so we're trying to still work on that, but there's definitely some early signals that some patients develop long-term lung fibrosis that results in chronic hypoxia and maybe something like a COPD in the end, although it's pretty early for us to know for sure. That does seem to happen in SARS-1 in China. There's data on that. So kind of expecting something like that. But the truth is we don't know who's going to be those people and who's going to recover fully. We don't know right now. And that's one of the things that we want to study with the grant that we were given to study this long-term COVID sequelae. To do that, we're working on starting a protocol where we would get pulmonary function tests and CT scans of the lungs and a cardiac echo on every patient for a period of time, and then serially. So we would get the first one within the first month of their illness and then get serial studies to see how they change over at least 6 months, although we may extend it to a year, and then compare that with blood work that we have on them so that we could try to figure out who's going to get really bad and who's going to recover all the way, because we don't know yet.
Yes, absolutely. And we have a significant amount of young patients in the clinic that are still symptomatic months after having the initial infection. So it will be interesting to see what comes out of the sequela study is definitely something that we are trying to learn more about. Great. I think we have 5 more minutes. Do we have time for another question or?
Sure.
Yes.
All right. All right. So the last question is about reinfection. Have you seen any cases of reinfection?
Good question. We were debating this yesterday and this morning. So, obviously in the literature, there's reported some cases, but they had to use genomic analysis of the 2 samples to prove if they were a new strain of the virus and a reinfection. So we had not been biobanking our specimens before, although now we got approval to biobank specimens. So we, in the future, will be able to know, but right now we're not sure. But I think Dr. Perez-Colon knows more about this possible case that we were thinking of yesterday.
Yeah, absolutely. So we have a young patient who tested positive initially in mid-July. And initially the symptoms were very vague and very mild. As a matter of fact, a patient developed symptoms, went and got tested, and we called her the day after, and she was completely asymptomatic at that point. So the symptoms were very minimal. And in a couple of days ago, so 88 days exactly after her initial infection was diagnosed, she developed new symptoms that were a little bit more significant than the symptoms that she had before, with some muscle pains and weakness and headache and fever. And at that point, she got tested again, and the antigen test was positive. We're still waiting for the PCR testing for her. It was collected, but it's still pending. So we're going to see if that one is positive too. And it is hard to say. I know that if we base on the data that came out from was published on Nature in regards to how long humoral or antibody immunity lasts in the system, it is possible that this is a reinfection. Especially since she has symptoms consistent with it right now, but it's going to be hard for us to determine whether it is or not. So we are in the process of developing a protocol for these possible reinfected patients at this time. All right, great. So I think we're out of time. I want to say thank you so much for everyone to join and listen to this important topic. COVID-19 is not over. We're still learning about it, and it is really important that we don't only focus our efforts on the inpatient side, but also on the outpatient and sequela side. If you have any further questions, either Dr. Oxner or myself will be happy to answer them. We can provide with our emails, and we'll be happy to answer offline. Thank you so much for joining and listening to us. And I hope that this was productive and informative.
Thank you, guys.
I hope you have a good rest of the day, everyone.